Well, hi, everyone. Good afternoon. I am Michael Morella, managing editor of events at US News and World Report. Thanks to dramatic advances in research, diagnostics, and treatment, more than 97% of children born with congenital heart disease now survive until adulthood. For people of any age living with CHD, the menu of care options can include surgical interventions, implanted devices, medications, lifestyle changes and support, and so on. In a few moments, I'm very pleased to welcome a group of experts from several of the nation's best children's hospitals for cardiology who will unpack many of the innovations and challenges still happening in the world of ACHD. Our thanks to Children's Health for their support of today's session. Now, before I welcome our panel, I just want to make a quick plug about the US News Healthcare of Tomorrow conference, which we'll be hosting in Washington, D.C. this summer on June 17th and 18th. There, you can join your peers from across the country to examine some of the most urgent issues affecting healthcare, such as the impacts of AI, policy changes, the evolution of post-acute care, and much more. Registration is officially open, and I do hope you could join us. You can learn more about that event as well as all of our speakers today and other virtual offerings from US News at usnews.com/events. Now on with today's program. Please join me today in welcoming Dr. Karen Goldberg, the Ruth H. Strang Professor of Pediatric Cardiology at the University of Michigan C.S. Mott Children's Hospital. Dr. Goldberg is the Director of MCORD, Michigan Congenital Heart Outcomes Research and Discovery at U of M's Congenital Heart Center. Dr. Jamie Jackson, a licensed clinical health psychologist, principal investigator in the Center for Biobehavioral Health at Nationwide Children's Hospital, and an assistant professor of pediatrics and psychology at Ohio State University. Dr. Carrie Schaefer, director of the Adult Congenital Heart Disease Program and an associate professor in the Department of Internal Medicine at UT Southwestern Medical Center and a cardiologist there and at Children's Health. And Dr. Elizabeth Young, a cardiologist at Children's Hospital Colorado, an associate professor of clinical practice and pediatric cardiology and adult congenital cardiology, the University of Colorado Anschutz. Thank you all so much for joining us. Now I'll turn it over to my colleague, senior health editor at US News, Shanley Chen, to lead the conversation. Over to you, Shanley.
Thank you, Michael. As you mentioned, the clinical success in this field is nothing short of a miracle. But for clinicians and families, we know that reaching adulthood is only half the battle. A comprehensive approach isn't just about adding years to life, it's about adding quality to those years. Today, we're here to discuss how we bridge that gap between pediatric medicine to achieve that whole person model of care, how we integrate mental health into cardiac care, and how leading institutions are retooling their systems and approaches to support a patient's heart and their life throughout their years. But before we get started, I'd love for each of our panelists to tell us a little bit more about their work, research, and initiatives in the clinic and community. Dr. Schaefer, can you start us off?
My pleasure. And thank you so much to US News and the other panelists. I think this is going to be a great webinar. So I am an adult congenital cardiologist at UT Southwestern and Children's Health, and I work at both institutions, which allows me to kind of do what we're talking about today, bridge the gap between the pediatric cardiac care that patients receive and then bridge them into adulthood. I trained in internal medicine, then adult cardiology, and then I trained in adult congenital cardiology in Boston, and then I've joined UT Southwestern and Children's. My research predominantly focuses on exercise and sports participation. In particular, right now I'm working on a study understanding better the way that blood flow and exercise are affected in the setting of having a Fontan circulation, but I've done other projects and exercise as well. Another focus of mine is in education, and I work a lot with medical students at a couple of different institutions, including our own here at UT Southwestern.
Excellent. Thank you. Dr. Goldberg?
Hi there. I will just add a thank you from me too to US News for hosting this panel discussion, and to you, Shanley, for moderating, and the rest of the group. I'm a pediatric cardiologist here at the University of Michigan. My emphasis clinically is in acute care cardiology, so inpatient care. And one of my greatest joys is seeing our patients who have been critically ill, recovering in the hospital, then coming back to CS and clinic, and then helping them to develop their best quality of life that we can reach. And I think Carrie hit it. I have emphasis on neurodevelopmental outcomes, but all functional outcomes are just so important for our patients with congenital heart disease that we now recognize as really a multi-system disease, not just affecting the heart, but affecting all our systems. And I bet we'll talk more about that as the day goes on, but that's part of my work here.
We certainly will. And Dr. Young.
Thank you so much for having me here. I'm really excited to get to meet the rest of the panelists and figure out some new ideas for our program and to share that with everybody else too. So I'm a pediatric and adult congenital cardiologist, and I still see the full gamut of children to adults, so newborns to probably 70-year-olds. And so naturally, along with that, a big career focus of mine has been transition and keeping those patients in congenital cardiology care wherever that may be best for them. I would say over the years, one of the biggest impacts that I've felt like I've had has just been that community involvement, working with groups like the ACHA for regional meetings and committees, and then in addition to different nonprofits supporting our local patients. From a research perspective, I've had a lot of involvement in the multi-institutional studies looking at our adult patient population, because in reality, this is really a small group of people compared to the general adult population, and they kind of need that multi-institutional support to be able to come up with really valid outcomes for these patients.
And last but not least, Dr. Jackson.
Thank you for the opportunity to be here this afternoon. I'm really looking forward to this discussion. So I am a clinical health psychologist, as was mentioned. I'm really focused in research right now at this stage in my career. And a lot of my work focuses on disease management, which falls kind of squarely in that transition area. How do we get folks to engage in health behaviors that can help them age well into adulthood and older adulthood now, as we're seeing with these patients. And in addition to that, I'm also really interested in how that best services medical outcomes, but also, not surprisingly, given my background, things like quality of life and mental health outcomes as well. Some of my current work is focused actually, Dr. Schaefer, you and I should get together at some point on physical activity intervention work. And how do we get teens and young adults with moderate and complex forms of CHD to be more physically active on a regular basis, since we know that's such an important health behavior for these outcomes that we're all really interested in for our patients.
That's wonderful. Thank you. Thank you, everyone, for sharing a little bit about yourselves and your work. Let's start by talking about what makes treating congenital heart disease patients a distinct field of its own. Dr. Schaefer and Dr. Young, you both mentioned that you have this unique vantage point of both ends of the age spectrum, specializing in both adult and pediatric cardiology. You've also mentioned, Dr. Schaefer, that ACHD patients have a unique heart anatomy, healthcare needs, and diseases. From your perspectives, can you both expand on what makes people with ACHD so distinct as a patient population?
That's a great question. And I think that, I think we could probably talk the entire hour on all of the aspects of it. I think already from the introductions you've heard, I think you can see that there are difficulties in really every aspect of care. So the areas that I think are most difficult, I think number one is, as Dr. Jackson outlined, the mental health component of adults with congenital heart disease is a very unique population because they have, PTSD related to their prior surgeries, and also just oftentimes a difficulty in coping with like regular life because they always have in the back of their minds the fact that they may at any point decompensate and need to be in the hospital. I think other things is just like transitioning into adulthood, whether it's maintaining insurance or maintaining employment, developing, partners, starting families of their own. That's a big component. But I think that another component, and I'm sure Dr. Young is going to have more too, I hope. Another component that I think a lot about is the multidisciplinary nature of adult congenital heart disease care. Because our patients, not only do they have mental health issues, they often have other organs that are in fact affected by either their prior surgeries or by their heart disease itself, whether it's lung disease, kidney disease, liver disease, vascular disease. There are many other components that our patients have. And so that's another unique aspect that I hope we can explore today, is just the concept that it really takes a village of very skilled and thoughtful providers to meet the ACHD patient where they are.
And I just wanted to offer another perspective too. Completely agree with everything that Dr. Schaefer said. But from a patient perspective, I think this is just a really hard diagnosis, regardless of whether or not you have like the simplest defect of just a hole in your heart to the most complex ones. This is something that they were born with, which there's a lot of guilt involved with that, with the parents, even though they're probably no fault at all in that. And then it's also very complex in the sense that even when you talk to other doctors who don't know congenital heart disease, most of the times they don't actually know what went into it and what the surgeries were and how to manage these patients. So this group of patients really sits on their own, and really requires the subspecialty to be able to support them. And I think it's hard because they can't just talk to another friend who had a congenital heart disease, because most likely their pathway, their disease is completely different than their own story. So I think there's a lot of isolation out there, and I think that would be one great thing if we could explore more too at some point, is that psychological aspect and how we can support these patients moving forward.
Absolutely. That's very interesting, because I think a lot of people may, at this very surface level, think of congenital heart disease as simply affecting the heart, but clearly it's very, very impactful for all the different organs involved, like you mentioned, Dr. Schaefer and Dr. Young. Dr. Goldberg, I know that you mentioned that your research focuses on the neurodevelopmental side of things and the long-term outcomes for children with CHD. What have you found in your research that kind of further illustrates why CHD is such a unique and complex disease to treat, like Dr. Schaefer and Dr. Young had mentioned?
Yeah, thank you. It's such a great question. And I really do think that congenital heart disease, like others have said, we think of it as affecting the heart, but it really has so many implications for the whole body and including the brain. There are probably, myriad exposures that put children with congenital heart disease at risk for neurodevelopmental impairments. And really we started to study neurodevelopmental outcomes and how to improve those outcomes in, really there were some early studies in the 70s, but really, quite a bit of work in the 1990s. And but it wasn't until the early 2010s that centers started to have neurodevelopmental outcome programs for the clinical care of patients with congenital heart disease. So we were identifying what the problems were and what the risks were. And then we realized that the best way that we were going to influence change and improvement was probably not surgical changes, but multidisciplinary involvement to identify what the impairments could be and to get patients the therapy that they needed. And now, more and more sites have programs within the hospital setting and outside of the hospital setting to improve, focused on improving neurodevelopmental outcomes. And it requires the multidisciplinary involvement. We as cardiologists don't really know how to do that in general. A patient comes to someone's clinic, you're asking about their arrhythmia, and people might say, how's school going for your child? And they'll say, oh, good, they like their teacher. And we don't ask any other questions, right? So we need specialists like Dr. Jackson. We need teachers in our programs. We need therapists. We need, like a slew of people to help our patients who are at risk. I got off topic a little bit about what makes people different with congenital heart disease, but I think it is the exposures at multiple points across the lifespan that requires us to pay attention to learning and development to improve quality of life for these patients.
I thought it was a great tangent and I thought it was very applicable. But Dr. Jackson, I mean, even Dr. Goldberg had mentioned the importance of taking that psychological approach as well. From your perspective and in your work, can you also explain why CHD is such a complex disease in your patients?
Yeah, thank you. I love what Dr. Goldberg had just said because I think it does highlight how heterogeneous this population is. We're still trying to figure out, who is at greater risk for some of these neurodevelopmental outcome differences over time, what happens as folks age. And from the psychology standpoint, I also just want to highlight that that also has a direct implication for their mental health. So folks who do have more cognitive challenges also are at greater risk for increased depression and anxiety symptoms, which are also things that need to be dealt with. And one thing I just wanted to highlight for the audience, just in case this isn't a language or discussion that's often heard among some of our listeners. One of the important factors, not just from a quality of life standpoint for our patients as far as addressing mental health outcomes, but I also just want to point out that it also has implications for cardiovascular health. And, there's a lot of research out there in acquired heart disease, and we're starting to gain some of this research in congenital heart disease about how the mind and the brain are really connected. And so, when depression and anxiety goes untreated for long periods of time, it really does place wear and tear on the cardiovascular system in a lot of different ways. And so we really are talking about a population here that's vulnerable, I think, on multiple fronts and really does necessitate this multi-pronged approach for addressing their concerns.
Absolutely, absolutely. So as we've noted before, that 97 survival rate is a major triumph thanks to improved treatments and success in managing these conditions in children. But it's a bit of a double-edged sword. As more children are living longer into adulthood, that also means that a majority of individuals with CHD now require lifelong specialized care. Can you all explain why it's important for these patients to continue receiving care, even if their treatments and management as kids were successful?
Shanley, I'd like to start there where one of our congenital surgeons, who was one of the grandfathers really of cardiothoracic surgery, he said when he started operating on these patients, he didn't think he'd be doing a second, a third, a fourth, or a fifth surgery on these patients. But the reality is, and for good reasons, that they're living a lot longer. And so every single time we have to reoperate on a patient, their morbidity increases significantly. And in the hands of maybe not the wrong surgeon, but just not a well-practiced surgeon, it's going to change their outcomes significantly. And I think a lot of patients don't realize that not everyone who they come across is as well versed as they are. So that's one piece of keeping them within our system. And then really looking out for, aside from the psychologic, effects of knowing that you have something coming up, another morbidity coming up, is actually trying to prevent some of these and to warn the patients about what they can expect in the future. So instead of the black box that it used to be of you can't have children, you can't exercise, you can't do all of these things, now we're like, you can do these things, but this is what we want you to look out for. So we're really shifting towards a more preventative approach in my mind, and a more realistic approach as well.
That's such a great point is I think that, the lifelong aspect is kind of the stories being written right now. And so it's impossible for patients to be fully educated on what they're going to miss out on by not being in adult care because we don't even know. Your colleague, Dr. Young, I've worked with many people too who really gave the patients a very false sense of security, or despair, whichever it was, and either way they're incorrect. I used to have a patient that every time he came to clinic, he would say, I'm, whatever age he was at the time, 55, 60, whatever. And the surgeon who told me I would be dead by 30 isn't alive anymore. And he it's kind of morbid, but he would laugh every time because it was such a traumatic event for him to be told that he was going to be, not going to be alive at 30. So I think that's a huge component. And I want to just highlight one other thing that you said, Dr. Young, which is that really, quite frankly, ACHD patients do better in congenital care for reasons we understand and reasons we don't understand. I think all of us on the call can probably think of an example of when a simple congenital heart disease lesion was operated on or had a procedure by people who had a perceived knowledge, and then ended up having an unfortunate and preventable outcome. And there's that really important study that I know we all highlight all the time in our literature, out of Quebec, showing that adults who stay in ACHD care have a demonstrable, meaningful improvement in mortality, which is like amazing, right? But important, right? That's huge because we're taking the sickest patients, we're keeping them in care. And even without the unaccounted for variables of the complexity of care, we're still just demonstrating better outcomes. And I think it gets at a lot of what you're saying, and I'm sure the rest of the panel agrees, that we just can't explain. There's no shortcut to understanding the complexity of ACHD care. And so if we don't do it together, the patients lose out.
I think one of the tricky things that has happened, I guess one of the ideal situations is that we now have a field called adult congenital heart disease. And, it used to be that it was just as the cardiologists got older, they were taking care of more adults. There wasn't anyone who had the expertise in adult care who could provide excellent care, outstanding care to an individual who was born with congenital heart disease, who had a complex situation, and also have the knowledge of other things that might happen to a 30 or 40 or 50-year-old patient. So now that we have this field of adult congenital heart disease, it's clearly just so important. And then but the challenge for all of us is to make sure that they don't get lost in the transition. So we spend a lot of time trying to make sure that we have our patients really prepared to follow up with someone who is the best equipped person to be able to take care of them when they're in their 30s and beyond.
Absolutely. Clearly, CHD is an evolving field in many ways in terms of taking that realistic preventive approach. And as you mentioned, Dr. Schaefer, like there are no shortcuts to that care. And speaking of which, CHD, as you all had mentioned as well, doesn't just impact the physical health, but Dr. Jackson, even you had mentioned that there is that heart-brain connection and that and how anxiety and depression can contribute to cardiovascular risk. So it's all involved. It's a very connective system. Can you further expand on what role treating mental health plays in lifelong management of CHD?
Oh, sure. I mean, it's such a critical aspect of the integrated care that these patients really require. Ideally, in an ideal sense, we would be able to, screen everyone who came in through clinic to know whether or not they're currently experiencing distress. We would have a host of referral resources, hopefully in-house, to have those folks see these individuals, a support team, be it social work or psychologist, a mental health provider of some type, and that they would receive treatment, and it's all kind of part of the package. Unfortunately, both given workforce, issues and not having the number of mental health folks available that we really need to treat this population, other kind of flow issues with clinic and how, our electronic medical record system is set up, like just there's a lot of different barriers that are kind of in our path for designing the multidisciplinary integrated clinic that I'm hoping that we eventually can continue to work toward and we aspire to. But I do think that in an ideal sense, and this is certainly something that oncology has a really good model for historically, is this integration of psychological services into care. And I think we can continue to look towards our colleagues in that department for some notes on how, us in cardiology, both within ACHD, pediatric cardiology, but even acquired cardiology as well, can look to ramp this up for the patients that, they need services now.
Definitely, definitely. And so I understand that unfortunately, many of these people don't get the care they need, even though it is so important for them and so critical for them to continue getting that specialized care. Can you all explain why exactly that is? What is preventing them from getting that specialized continued care that they need? Dr. Young, I know that you specialize in bridging that gap for patients from pediatric to adult care. What are the biggest challenges you're seeing in adults getting that required treatment and ongoing care that they need?
Yeah, I mean, I think that there's been a lot of studies looking at the different barriers to care, and some of them are, I think having that acknowledgement of that, we can actually work around some of those now. And in my mind, at this point, there's a couple of big factors. One is where is their medical home, right? So we know that these pediatric patients, especially if they're diagnosed early on, have a strong attachment to their pediatric hospital. But at every center across the nation, it's probably a little bit different. So not the pediatric center is not the best place for every single patient in every single city. And the adult hospital isn't the best place in every single city. So everywhere you go, every time you travel, it's going to be a little bit different depending on how the system is set up there. So there is that piece of it and the emotional attachment to the medical home. And then we also have insurance barriers. So there are people who just cannot go to the place that they know they're supposed to go because their insurance does not allow that. And sometimes you can have a workaround, but sometimes the reality is that it is just not possible with the current insurance that they have to be able to get the care that they know and that we know that they need. And then, there's other logistic issues like, for example, in our city, there's a lot of different medical systems, and some of them communicate well with each other, but other ones don't. And so when we're talking about the complexity of care that some of these patients need, and that it is not possible really logistically to ask them to travel an hour or two to come to your hospital to get every single other subspecialty care that they need when they can get it closer. It's just very difficult to communicate with these systems and to be able to then provide that comprehensive care. But I think that probably circles probably about 70% of those issues as far as of some of the barriers to care there.
Can I just add one more that, of our patients with critical congenital heart disease, about half of them will have some kind of neurodevelopmental impairment. And so if our patients have some challenges with a learning disability or executive dysfunction, they may not understand, or it may take some extra effort to make sure that they understand what the possibilities are for the future and why they really need ACHD specialists to care for them going forward. So I think the onus is on all of us to make sure to be encouraging about the possibilities and yet also very instructive from very early ages about what the need is going to be for their long-term follow-up. So the expectations are in the right spot, and there won't be any question going forward that they need an adult congenital specialist.
I think that's such an important point, and I like underline and highlight completely what you're saying. And I would say, in addition to that, one of the things that I've tried to do here, and I'm sure you all are doing as well, is it's, we have the transition education that happens when the, child, Dr. Young, as you're talking about, kind of needs to start somewhere around 12 to 16 or something like that, so that the identity of care doesn't rest with solely a single person. They start to become aware of the fact that their care team is going to expand. But I think one of the things that, we've been trying to work on here is the education of the entire health system. Maybe not the entire health system, maybe I'm being too broad, but the person that answers the phone call to make the schedule, the person that talks to them in clinic, it's really important, in particular in the adult hospitals. Pediatric hospitals are sometimes a little bit more used to this, but in adult hospitals, they're not used to 40-year-olds that can't do simple math, or, just the things that you're talking about that your research has highlighted, Dr. Goldberg. When they reach adulthood and they look like people that aren't going to have those problems, we have a lot of adult providers that either undereducate or undercommunicate or communicate frustration, and either of those things puts a giant barrier in care when they're already suffering with things like depression and anxiety, and they're still feeling that their medical home is not there. I think all of these things are really critical. And I think the adult side of things, we need to get better at educating I would say the non-physician component of staff to ensure that everyone understands the neurodevelopment outcome issues that impact care.
Dr. Jackson, it looked like there was something that you wanted to add as well.
One thing that kind of struck me as we were discussing this, and Dr. Goldberg, I'm glad you also had kind of brought up the education component for our patients and just the understanding of, what that lifelong care means. I was involved in some work, so again, it's one site, and so it's really limited evidence, but there is some evidence to suggest that there's even a drop off in regular care starting between 0 and 5 years of life, so like after surgery. And I think this just kind of goes to show that, and Dr. Young, to your point, I think there's this confluence of factors that end up affecting these families as they're thinking about, I either can't afford, to go to the doctor, or I have a really high deductible insurance plan. Have I been given all of the information I need to understand the importance of this regular checkup on a yearly or every other year or every 6-month basis? And if I'm feeling well and my child is feeling well, do I need to pay that deductible? Do I need to, continue to go if everything seems fine? And so it really does feel like it's this tricky confluence of multiple factors that end up impacting these families. But Dr. Schaefer, I appreciate the fact that, these families do intersect with, their pediatrician, they intersect with all of these other folks, right, in the medical system, nursing, the call folks, and and can we educate everybody about the importance of ensuring that these patients are getting seen, per the schedule that they should be coming in. So that's all. I just wanted to add that.
I mean, and you bring up such a good topic about the intersection with different people in the healthcare system. And Dr. Schaefer, you even mentioned that there is a challenge for the people who look like adults without CHD or related neurodevelopmental issues. When they go to their primary care physician, do you think it's an important conversation for them to have about their, CHD and their related issues as well? I mean, is it very important in your expertise to loop in that primary care role?
I mean, absolutely, because there's only so much that the adult congenital heart disease team can handle. So we absolutely need to partner with our PCPs. But I think one thing that we probably all should maybe as a field be working towards is a little bit, easier forms of communication with those PCPs. Because sometimes it's easy because they're within our own health systems, but when it's not, we have these PCPs out in, rural components of all of our states, basically, where these primary care physicians have a lot on their plates. And so I think that's another area, there's just education across the board, whether it's non-cardiology physician providers, general cardiologists that don't do ACHD. I think the only way to solve all of this is to educate everyone kind of across the health system about the complexities that we're having. So things like this webinar is really great to help, bridge that gap.
Absolutely. And I definitely have a few more questions to ask about this multidisciplinary approach and the reason why it's so important. But before I jump ahead, I wanted to talk about this aspect of sports participation and exercise, which I understand that is a big focus of your work. Can you tell us a little bit more about why fitness, exercise, and sports are so important to the lifespan and health span of your patients?
For sure. No, I think all of us in adult congenital heart disease, I think we probably all feel the same, which is that physical activity is one of the only things we can do for our patients when it comes to preventing things like depression and anxiety even, or coronary artery disease, or giving just the reserve to get through whatever surgery that is ahead of them. I think sports participation is so key for children with congenital heart disease for sort of identity formation, and then also just like the things that sports teaches them. I think there's a lot of great aspects of that. And I think that we also know that inappropriate restriction from sports participation has lifelong impacts into the mental health of a person, and probably the physical health as well. And so I think that's one aspect. I think that I'm certainly, like many of you, kind of working towards making sure, as Dr. Young had said, you can participate in sports. I know your pediatric cardiologist 10 years ago said you couldn't, but that was because that was a different, set of data. And now we have, the reason, I've been talking about this a lot lately is because I was on the guidelines that were just published about competitive sports in congenital heart disease, was the aspect that I focused on. And we really tried in those guidelines to be as thoughtfully unrestrictive as possible, but then as thoughtfully, kind of limiting. Only a few conditions were listed as conditions that the risk outweighed the benefit of physical activity. And for the vast majority of heart conditions, we tried to give kind of a guidance of what kind of evaluation patients could undergo. And then in collaboration with an ACHT provider, the consideration of our participation in sports. And then exercise, of course, everyone would benefit from. So I think that's another avenue that I love to talk about, but I know other people have more to say about exercise, so I'll pause for a second and we can loop back.
Yeah, thanks, Dr. Schaefer. No, that was excellent. From my own work, some of the factors that we've seen in teens and young adults, as far as what kind of plays a role, at least in association with physical activity levels, are things like their self-efficacy, so their confidence in their ability to actually be in physical, moving their body, as well as social support from their family and friends. And I think that does play a really big role in sports engagement and whether folks get exposure to moving their body in this way as a younger person. And that does likely, I mean, we don't have the longitudinal data to support that, but I think a lot of us would guess that over time that does have an impact then in how physically active folks are over time. And I was just going to throw out there one thing about, what we've been trying to do with my study is we do put everybody who's involved in the study through an exercise stress test, in part so that we can quell any of their concerns about their ability to engage in physical activity. And I think exercise stress testing and an exercise physiologist and a discussion with that exercise physiologist can really go a long way in helping patients understand what they are and are not capable of doing. And more likely than not, they are capable of doing quite a bit, more than they probably think they are.
I'm sure to them that's like music to their ears.
Yeah, I think, we have a exercise program here now, like where we give prescriptions, and we've had a program that we call Heart Club, and it's been remarkable, just to your point, the kids who didn't think that they could run, that they could play soccer, and when they have had some appropriate training and been able to practice, then of course, for so many kids in so many situations, they actually can participate in those activities. So we know, we're hoping to avoid that self-fulfilling prophecy or doctor-induced prophecy or whatever, healthcare-induced prophecy or parent-induced prophecy, by just showing people what they can do and allowing them to show themselves.
Dr. Young, especially since you specialize in transitioning from pediatric to adult care, I'm sure that is a big part of the conversation you're having in transition education.
Yeah, absolutely. For all the points that everybody else mentioned, but the other key thing that I like to talk to my patients about is that symptoms, it typically is a huge player in whether or not somebody meets criteria for surgery. And so I personally tell them it's a lot easier for them to differentiate whether or not they're a couch potato or if they're actually feeling a genuine change in their exercise capacity if they were doing exercise regularly. And, I think that there's a lot of strength in that for patients because then they have more agency as far as whether or not they're going to need this surgery. They can control that small piece of things a little bit more. And just any motivation that we can give them to exercise, for the health reasons, for monitoring, for the psychological health, all of that, the better, I think.
It's so funny. I literally do the exact same thing. I actually, now that you're saying this, I recall I recently saw a patient that moved to Texas from Colorado, and I'm like, oh yeah, I did see that in your note. So I will attest to the fact that she does this routinely. I think that's wonderful. And I was actually thinking about another comment that you had made, because one of the things we're not talking about right now is what's going to happen in 10 or 15 years, because the survival rate suggests that we're going to have a heck of a lot of 50 and 60-year-olds with congenital heart disease in the next 10 years. And wow, is it going to be difficult if they all have coronary disease and diabetes? So that's one thing that I think, even though we don't necessarily have the statistics yet, to show us that that's going to happen, we know that that's the reality of living in the United States, quite frankly. And so that's the other thing I keep thinking is, I tell my patients, like, look, you've already had 3 sternotomies. How about you don't have a 4th because you have coronary artery disease? And that definitely motivates them as well.
Absolutely. And I imagine that also really underscores that the importance of multidisciplinary collaboration with, from the mental health aspect, from the physical and the heart health side and of course the primary care. Everybody is involved in this holistic approach, and multidisciplinary approach. So let's continue our conversation about that, because I feel like that's such a big theme here, among everybody on this panel, this theme of collaboration and making sure that you work with other specialists in different silos, or rather breaking down those silos. Can you all talk about what other initiatives you're doing at your institutions to cultivate that culture of collaboration to make a bigger impact?
I can start because we are collaboration is central to everything we do. It's both multidisciplinary collaboration. So we have exercise team members working with our patients on exercise. We have a teacher engaged in our congenital heart center to help kids who are having issues with school, with learning, and if they need help with their IEP. We have psychologists who work with our group and centered within our congenital heart center to help to make sure we're available to help treat mental health issues and actually help to build resiliency to deter problems from mental health issues. I think the other piece of collaboration that is important to note is not just the multidisciplinary at each of our centers, but the multi-center approach, which includes multiple disciplines as well, but multi-center approach so that we're learning, it improves our quality improvement work, it improves outcomes across centers that participate in multi-center collaboratives. And from a research perspective, we're able to answer questions that are going to be important for the next patients who have congenital heart disease through putting our clinical efforts together to understand what's going on with our patients and what are the things that put them at high risk and what are the treatments that are most helpful. So collaboration is key. Totally key.
I love that. And I'm really interested in what you said about the multi-center collaboration as well. How do you address some of the challenges there with the hospital systems that are trying to stay competitive with each other? How do you cultivate that collaboration across institutions when you have that competition between systems?
Yeah. Well, I think that every site wants to have the best outcomes possible. And if we know that participating in collaboratives helps to improve outcomes, and then that's going to be something that even the people who are not congenital heart specialists, but in the administrative suite, they will want to support that. Everyone wants to support the health of our patients, and we want to show that we're doing the best that we possibly can. And we have identified that collaboratives are part of that, part of getting to the best care for each of our patients at our sites. So I think it's sometimes there's a fund investment that there is a fund investment to participate in collaboratives, and it is so important just to show what the outcomes are and why it's so valuable to our patients and our centers.
I mean, it's an important question, to think about, right? Of the competition component of it, because I think that's the reality of our healthcare system. But I don't know, my experience with adult congenital heart disease providers is that we're a very special group of people that very distinctly care about patients. All of us on the call today and all of the people I've worked with across the country. I mean, it's just you can't really go into this field if you don't really care about patients. And so, I have, hundreds of examples of calling up colleagues across the country, and immediately that person drops everything that they're doing to help me care for a patient, irrespective of whether or not it's going to benefit their career or their institution or whatever. So for now, I would say, and hopefully this is forever, this is a special group of people that care for adults with congenital heart disease. And I think that thankfully has been, sort of the pathway forward. And I think we just, as a community, need to continue to do that. There are these special conferences that happen every year for ACHD providers. And I think that's a really important reason for why all of us stay connected and collaborative.
Carrie, that was so sweet. But also wanted to add from a local's perspective too, that I think adult congenital heart disease is really challenging. And so a lot of our general cardiology providers don't actually want to see these patients, and they recognize that there is a subspecialty and they need to be taken care of by the subspecialist group. But my point behind that was that I do think even though we recognize ourselves as the right place for some of these diseases, that there are a lot of things that our counterparts can actually take care of. And I think that if we acknowledge that as well, that, if it's a coronary disease situation, that they are very well versed in coronary disease, and to allow them to help with coronary disease management, diabetes management, or a lot of the other things, a lot of electrophysiologic things that aren't complex, they are very good at. And I think that if we acknowledge that to the patient and to the rest of our team members and community, that we can continue to have that collaboration and that ability to move across systems, knowing that you're outside of that institution and that money fund, but you will get returns because we are therefore sharing the patient and doing the best for the patient ultimately.
Absolutely, really focusing on that patient. Sorry, Dr. Schaefer, you were about to say?
No, I was just going to say, one thing that your thoughts kind of had me thinking is I have an evolving thought in ACHD care in adult hospitals, which is that ACHD patients are sort of a stress test for the health system in and of itself. And so one of the things that I think we as a community can do is to sort of serve that role within our individual institutions to highlight the areas where the care gaps exist. Our patients need cancer care. They have an increased risk of cancer, right? They have an increased risk of all the other organ diseases that we talked about. And so I think that, number one, I would say for the hospital administrators out there, pay attention to your ACHD providers because they know what gaps exist in your care right now. Because there's really no area of medicine, obstetrics, gynecology, anesthesia, neurology. I mean, there's really literally no area within a healthcare institution that ACHD patients don't at some point or another interact with. So the first thing I would say is that from the administrator side of things, like there's a lot of knowledge we have to provide knowledge for. And then the second thing I would say is like Dr. Young is saying that we need to create, and we have at our institution, we have a couple of different working groups where we've taken individual problems and there's like people from the non-congenital side of things and the congenital side of things. So our heart transplant team, for example, we have a special group of people that are working on that for the Fontan circulation. I know a lot of institutions, including you all, have special Fontan clinics. So I think that's the pathway forward to get more specifically to your question, Shanley, that probably a sort of specific collaborative working groups or committees is needed because there's really no way to educate everybody on everything.
Definitely seems like an ongoing challenge and an evolving challenge too, as you get more data and learn more from all of your longitudinal studies. Dr. Jackson, from your perspective, can you talk a little bit about what you've observed when it comes to working with different specialists and what can be done better?
Yeah, I mean, ultimately, I think our team has done an excellent job in trying to create as multifaceted as integrated of care as possible. I mean, we do have the benefit here in Columbus that our adult congenital team is both housed within the pediatric hospital as well as the adult hospital. And so, for example, interaction with folks like hepatology and maternal fetal medicine, so the obstetric side, has actually gone quite well. Coming back to the psychology aspect of those integrated services, there are certainly challenges with adult patients being seen in a pediatric hospital and then trying to get in-house mental health care. We do have an adult trained psychologist right now who is seeing our ACHD patients in the pediatric side. And then thankfully, we have somebody on Ohio State side who has experience working with folks who have heart conditions, including ACHD. So, from my standpoint, and again, I'm a little bit removed since I'm more on the research side. There is definitely a tremendous benefit of being able to kind of play on both sides of the fence, on the pediatric fence and on the adult side of the fence, in order to help facilitate some of this communication with these other providers that are really integral.
You all talk about it, and Dr. Jackson, I love that you talked about it as, playing on one side of the fence from the pediatric side as well as the adult side. Considering you all have kind of had experience in both the pediatric and adult side of things, what are some of the lessons in pediatric care that adult cardiology can learn from and vice versa?
Communication and collaboration, I think. Those would be my words. Yeah. I think that doesn't always happen on the adult side of the hospital without someone who's particularly focused on that effort.
So true. And I would say sort of like systems two thinking. I think that sometimes in adult medicine, we get very protocolized and thinking that every patient is going to behave in a certain situation a certain way. And I think that one of the things that adult providers can aspire to more is thinking about the patient as an individual rather than sort of another person with XYZ disease. And then I would say the pediatric side, I think, is appreciating that some of those protocols actually are helpful. So I think it's kind of taking both sides of yes, is a 50,000 study, a 50,000 patient study on this drug and this situation. And even though it's not perfectly assigned to our patient, we might be able to use it in congenital heart disease. And then the flip side of, but let's think about our patient individually and whether or not they would have met the criteria for inclusion, et cetera.
And I think from the pediatric side, there's definitely a lot more hand-holding, which is very beneficial from the adult side sometimes to not have as much hand-holding, but we probably need to remember that a lot of our patients being seen in the adult world are early adults, are 20 to 30-year-olds. This is still a very new thing for them and require a lot of hand-holding. And I think we can be a little bit gentler on the adult side, giving a little bit more grace to that population, recognizing that it's a huge step for them to take.
No, I think that's an excellent point, Dr. Young. And I was just kind of thinking about the fact that one of the neat things that I've seen both, in our institution, but I've talked with colleagues about this, is that I think there's more shared ownership that's starting to happen on both the peds and adult side about the importance of transition, instead of it kind of leaning, and it depends on the program, it depends on who you're talking to. Sometimes it's leaned more on the pediatric side as far as the responsibility to get, patients ready for that transition. I think that's historically what's happened. Sometimes it's fallen on the adult side. But I think now we're seeing better communication between those teams so that both are taking ownership. And I think that really is helping with this process so that support's coming on both ends, both sides of the fence, coming back to my metaphor.
I like the metaphor. It's a good one. We have a few minutes left, but one of the last questions I wanted to ask you all is, as we look ahead to the future, it seems like considering this is such an evolving field, there's more and more data coming in about the longevity of your patients, as well as the repercussions and the other health risks that they'll have to experience. What are some of the key concerns and challenges for the field moving forward?
It's staffing, I think. Our biggest worry is that we just don't have enough people graduating with ACHD fellowships. And so I think that's, there is no shortcut. So you can't teach somebody 10% of ACHD and expect them to actually, make a huge difference in care. I think we need to continue to train more people, adults with congenital heart disease. I think we as a health system, like a global health system, need to figure out better ways to support people who do want to do ACHD. And I think that we need to start at all levels of training, whether it's medical students or residents, or even before medical school. I think that's one area that we've just got to get on because we're never going to keep up.
I think too, given that these patients are living a lot longer, there are a lot of issues that are coming up. Like people don't qualify for insurance because they know that they have a congenital heart condition and are going to need repeat surgeries or other comorbid factors. So really navigating the costs in the insurance system, that I really don't see how it's going to continue the way it's been continuing, and have these patients be able to afford that the care they need, and have hospitals not spend an extraordinary amount of their budget on this very small amount of patients, which I know from the administrative side is not great, but there has to be some kind of balance that we can come up with.
From the psychology/neuropsychology perspective, I think one of the things I'm certainly keeping an eye on as well is just, what does this aging process do to folks who may already have some neurodevelopmental challenges? So Dr. Goldberg, you may want to speak on that in just a minute here as well. But, I think we're just wanting to keep an eye on what does that look like? How does aging that we see in a cardiovascular typical population look different from our adults with CHD? And then how can we provide, again, the best support services for those individuals that are entering older adulthood? And again, it's a new group, as we've discussed. So we're just now seeing what that might look like.
Yeah, thanks, Jamie. I totally agree with you. I think that for our patients with congenital heart disease, they have risks both when they're infants, maybe even, as a fetus, and then through their early childhood. And then again, the effects on the brain we're learning now are accelerated, some accelerated aging among our patients with congenital heart disease. So it gives us a lot of work to do, to figure out how to protect the brains of our patients, and how to be able to help them live their fullest, help our patients live the fullest lives that they possibly can.
I definitely don't want to end on a doom and gloom note of what challenges you foresee. So let's look at the flip side. At the bright side of things, what excites you most and gives you the most hope in this field, just to wrap us up?
I mean, I'm really excited about like the more collaboration between the pediatric and adult, institutions. I think it's personally really fun. And I think that there's nothing more gratifying than having patients who, didn't think they could exercise, didn't think they could compete in a 5K or something, and having them do that. I think that's amazing. And I think like I say, the partnership, I mean, we're building a new children's hospital that's going to be connected to the adult hospital by a bridge. So I'm really excited about that. But I think all of us kind of have that hope of more collaboration in the future.
I'd love to add that that there are so many technologic advances in what we can provide for our patients these days. So I love it when I can tell a patient that we can replace their pulmonary valve, maybe even their aortic valve in the cath lab, and not have to undergo surgery and spend 6 weeks or several weeks in the hospital and months in recovery. So those technologic advances is really what's exciting to me moving forward as far as giving hope to these patients.
I'm really excited about the fact that I think the generations to come have less stigma about seeking mental health care, which I'm actually really excited about. Folks are way more willing to say, yes, I want to see someone. Yes, I want to talk about how I'm feeling. And I also just want to, thank and congratulate my cardiology colleagues for really understanding the importance of psychology and mental health in this population, because it certainly, I think, is going to really help our patients moving forward.
Yeah, for all the reasons everybody has said, the collaboration, the improved technology, that so many things can be done in the cath lab, and the awareness of allowing our patients to be able to participate in exercise and to get the neurodevelopmental care that they need. I think all of those things are leading us to a brighter future as we go forward for our children with congenital heart disease.
That is very exciting and a wonderful note to end on. That is all the time we have for today. I want to thank you all, our panelists, for your time and your insights, and a big thank you to those in our audience who joined us either live or are tuning in later. You can learn more about today's speakers and other events coming up for US News, including our Healthcare of Tomorrow in DC this June at usnews.com/events. And I encourage you to visit health.usnews.com for deeper insights from my colleagues and me about heart health and so much more. Thanks again for joining us, and see you next time.
Thank you.